Hi everyone, happy Wednesday. We are back to doing our Wellness Wednesday live. So I hope you guys will join us. I know it's been a while and we had that moment of being deep in COVID and then coming out of COVID, going back into it again. And so what we wanted to do, Dr. Keith Berkowitz and I want to talk to you today about long COVID and some of the what you should expect if you have long COVID. And then next week, we're going to actually talk about treatments. So very excited to have Keith here. And if you have any questions, please post your questions here so that we can get some of your questions answered. So we're just waiting for Keith Berkowitz. How's everybody doing today? Where's everybody from? Where are you joining us from? I see people from the UK. I recognize certain individuals here, so thank you for joining us. Don't leave because we're having Keith join us in just a moment. We're talking about long COVID, what it is, what can actually happen long-term after catching COVID, and what you can do about it. We can talk about that next week. Okay, let's see. You have to request. Wait. Let's see if you can join. Hey.
Hey, trying to get my new setup here. Hang on one second.
I know it's been a while since we've done an Instagram live on our Wellness Wednesday. So yeah, you've got a different background and everything.
Yeah, I'm trying to take advantage of the sunroom. The skylight, I should say.
The lighting, yes, the lighting is good. We already got one guapa, so that's nice. All right. Well, let's just get started. Keith, thank you so much for joining. You're doing these lives with me, and it's so exciting because we're going to be discussing, our first topic, which we've been wanting to do for such a long time, is long COVID. Everybody's talking about long COVID. And thank you. Thank you. Someone's saying, good to see you, Keith. Hope you had a good vacation. So what is long COVID, Keith? I mean, I think you explain it better. For those coming onto the IG Live, what is long COVID?
So what's interesting is there's really no true definition, which makes everyone confused.
Yeah.
But we think of it as the post symptoms after someone has had acute COVID infection.
Right.
And that the challenge in this is the range of symptoms is so wide and so varied. It makes it often challenging to even diagnose. And I think a lot of people walk around having long COVID and don't even realize that they have it.
Yeah. And it's interesting, you don't really, what I'm finding in clinical practice is that even those that get COVID that don't know they have COVID, that then end up getting long COVID, have no idea that they're actually having symptoms of long COVID. Because your symptoms of long COVID can be, quite a bit more severe than the actual COVID itself.
Absolutely. And it's really interesting. I see more and more cases where they're like, oh, I never had COVID. Then we do what we call a nucleocapsid antibody, which is specific for COVID, which people who are vaccinated won't have. And they're like, well, it's positive, so I must have COVID. And what's interesting, what you said, is you can have long COVID, symptoms that are severe, with mild COVID symptoms. So they're not often correlated together, and that's what the challenge is.
So let's go back to that for a second, because a lot of people are asking to get their COVID antibodies tested to see if they have had COVID before. And the SARS-CoV antibodies, the one that has been done, the basic one, is going to be elevated if you've been vaccinated, correct?
Right. And that's the one we look at the spike protein itself versus the nucleocapsid antibody. So the difference between the two is the nucleocapsid, as you kind of think of as the outer layer of the virus. It's what we call the lipid layer that is necessary for transmission. Where think of the spike protein, it's almost like you have a weapon. We have these little spikes on the weapon. That's what causes the inflammation. So people that are vaccinated will have a positive response to the spike protein. People that had COVID, but a negative response to nucleocapsid. People who've had COVID will have a positive response to both.
Exactly. So if you're not sure if you've had COVID, get those markers tested, because if you're experiencing some long COVID symptoms or symptoms that you're not usually used to having, that's something to think about. And, by this time, everybody will have gotten this virus.
And, it's interesting, there was some recent, I like statistics, so I'm going to throw some at you, is that up to maybe 50% of people didn't know they had Omicron, which is the recent, wave since January. That's a huge amount of people. They suspect at least over 75% of our population, maybe even higher, was exposed to Omicron in some form.
Absolutely. And that's an interesting one, is that people are walking around asymptomatic and then getting these long COVID type symptoms. So let's look at the current medical thinking, right? So the conventional medical thinking, because naturopathic medicine is medicine. So I just want to, we're not doing woo-woo things. This is like proper looking at the biochemistry, looking at the DNA. What we want to look at is the conventional medical thinking versus the, things like naturopathic thinking. And what is exciting is next week we are having another naturopathic doctor, Dr. Paul Anderson, join us to talk about different naturopathic treatments for people with long COVID and COVID itself. But Keith, because you are a conventional medical doctor, but a damn good one, and what I love about you is that you treat very differently than your colleagues, really. I mean, which is, you're really open, and your way of thinking and your way of treating is super interesting.
Well, you have to think of medicine, it's dynamic. It changes every day. I mean, you have to change with it. And especially with an evolving science, I don't want to use that word science, evolving condition, you have to be able to be, flexible. And every day we learn something new. We learn something new about the virus, things that we didn't know before. I'll give you one interesting fact about that. There's now studies coming out from the digestive tract that the virus can actually remain there for over a year. So people can actually, so is it actually long COVID in some cases, or is it still acute COVID that has never really fully gone away? And that's one of the dilemmas we face with. Because if you have the virus still in your body up to a year, that's in a way still acute infection.
Yes, absolutely. And our gut is the foundation, like our digestive system, 70% of it is our immune system. So if we're having our gut affected by COVID, that is going to be huge. Somebody asked if probiotics will help. I'm going to answer that right away, because there are studies that have been done that people that were having a higher propensity for getting COVID had low good bacteria in their gut. So yes, probiotics will help you from getting COVID and also keep you healthy and prevent you from having long COVID. So basically, yes.
So it's interesting though you say that. There is some studies now done. I have a colleague, Dr. Zahn, she's out of California, nearby you, that has shown that post-COVID infection, bifidobacterium, which is one of the main phylum for the beneficial bacteria. We all know about lactobacillus, which is the most common one. Probably the second most common one is bifidobacterium. That's actually pretty wiped out post-COVID infection. And I think maybe that's why we're seeing a lot of issues post-COVID, because without a functioning digestive tract, your immune system doesn't function, your hormones don't function, your, blood sugar doesn't function properly. All these other processes are tied to the digestive tract really working really well and properly.
The other thing with COVID is people are more susceptible to long COVID if they've had other viruses. And yes. It's kind of like a gang. The viruses are like a gang. Think of them as a bad gang of, different viruses. And when one virus activates, all of them start to activate. We talk more about that? Because I'm seeing a lot of, people with Epstein-Barr, it sort of reactivates and they tend to get the symptoms of as though they had that Epstein-Barr virus all over again.
So Epstein-Barr virus is human herpes virus 4, that's in the herpes family. like shingles or, people get cold sores. And it's actually most known for infectious mononucleosis, which a lot of us remember having as teenagers, AKA the kissing disease.
The kissing disease, right.
And what's interesting with COVID about that is COVID, through something we call toll receptors, which are immune receptors, we find in a lot of the digestive tract, reactivates that virus in particular. The other ones that's interesting, besides viruses, people have had Lyme before. That sometimes could be reactivated. And the co-infections with Lyme, those are pretty common. Again, people have had shingles before, which is herpes zoster, can also be, re-triggered. And even oral herpes gets re-triggered. For some reason, and I'm not sure why, herpes seems to be very much re-triggered. Again, think about viruses that make them so different than other pathogens within our body. Oftentimes they remain dormant and they're there, right, and then they get reactivated by that. In addition, not only reactivation, which I've never seen before, I've seen a second bout of acute illness, which is very unusual, where I have a 50-year-old and a 75-year-old, both with acute, Epstein-Barr virus, which I've never seen before. And the way we can tell, and you talk about lab work, the way you can tell the difference is you look at what we call immunoglobulin M levels, which is a measure of acute infection within 4 to 6 weeks, versus what we call immunoglobulin G levels, which means old infection. And in the past, we used to think of when immunoglobulin G levels were high, it didn't mean very much. It was okay. But that's actually not probably true. We now know that the higher levels, the more of an antibody response, the more the body's having to fight off these immune issues. And why Epstein-Barr virus has become so important now, if you look at it like the genesis of some of the autoimmune diseases, there was a study recently on multiple sclerosis that Epstein-Barr virus may be one of the triggers for people later to develop multiple sclerosis.
Absolutely. It's really interesting. I mean, people don't realize that, if you have to do everything in your power to not get this, because there's so many things that can happen after the effect, or you need to arm yourself with, the appropriate tools, making sure your good bacteria is at the highest maximum level. You're taking vitamin C, taking vitamin D, all of this we're going to talk about next week. But all of these things are like armor shields that are going to actually protect you. You might get some leak of some of the virus, but it's not going to be potent enough to actually cause this disarray, which is, the one thing is obviously prevention, right? We want to try to prevent.
You know what's so interesting about this whole COVID pandemic? It's really shown how integrative care has been so effective, right? That we now know vitamin D, vitamin C, probiotics all really have such a dramatic benefit in not only preventing infection, but leading to much more mild response to infection.
Let me tell you a secret, Keith. We've always known this.
Well, that's because you're a naturopathic doctor.
Yeah, we've always known this, but it's only now that the mainstream are knowing.
It's actually kind of funny you say that. I have two colleagues that we talked about in the beginning. They were, very, like vitamin supplements. Yeah. Now they're like, oh my God, this is a great thing. I'm like, yeah, we've been trying to tell you for 3 years. But now I think for the first time, which is really interesting, it's now really out there in the literature, really showing how important that is. And I think that's so critical for us to really prevent disease down the road and in the future.
What are the statistics again? Was it 5 to 12 times more likely to get COVID if you were low in vitamin D?
Yeah, that, and I think, I don't remember the exact number, but the one I did see, I think the mortality rates were really, really, really low with normal vitamin D levels. And that's an interesting point. So when we look at the lab values, they use the term 30, right? 30 is considered. Yeah. But probably that's still insufficient. Probably we're looking more like 50 to 60 levels to be really protective. And the reason why vitamin D is so important is, at least we know with the original strains of Wuhan, is that it binds to what we call ACE2 receptors. That's how the virus enters the body. Guess what vitamin D does? Vitamin D becomes a competitive to bind to those same receptors. In fact, in Brazil, they were actually using very, very high doses of vitamin D, up to 100,000 units, to actually treat. And there is actually literature in overwhelming infection in people that are in the intensive care unit of using very high levels of vitamin D. What's different though, you and I on a preventive basis take vitamin D3. in the acute care basis, you actually use vitamin D2 because it's much more effective in getting there quicker.
Right. That was great. I want to answer one question here as we go on. I have sobbed for over a year. I have no antibodies and no T cells. Is it still possibly long COVID? Not sure what that.
So here's what's interesting. I've had shortness of breath for over.
Oh, shortness. Yes, sorry. I wasn't reading that right. I was thinking I've been sober for over a year, so I was like,
So here's what's interesting, and I have to, and I've seen this with other people that, like, I've had cases of Epstein-Barr acute with no COVID. So people can have other infections, and what's really interesting, we're seeing a lot more viral infections in the environment. And one of the key points, and again, every individual is different, viruses tend to cause something called pleurisy. And what that means is inflammation around the lung lining. Pleur is the outer lining of the lungs. And it's a very normal symptom post-infection. In fact, I had long COVID. I had COVID back in March of 2021. And 2 months later, when I started exercising again, I got shortness of breath, even though my oxygens were normal. And it was actually a form of pleurisy, where the outer layer of the lung almost felt restrictive. And when I try to take a deep breath, especially with exertion.
Yeah, and then we have to think about things like vitamin A, because vitamin A is super important at supporting mucous membrane type reactions. So there's like a lot of different vitamins that you can actually use to help clear out that infection and also rehabilitate that.
And remember, that's really important actually with Omicron. And what's different about Omicron, and someone talked about MCAS, which is mast cell activation syndrome. Omicron seems to be much more histamine mediated. So those mucous membranes, both in the nose, nasal, remember nasal passage is where we first see it. That's where vitamin A really works so importantly in those mucous membranes, because that's really, in a sense, your first line of defense to prevent infection.
Okay, so we have the post-COVID, we have inflammation, any post-viral, there's a hypercoagulable state. Let's talk about that, because that is getting a lot of attention in Europe. A lot of people are going to places like Germany to get certain treatments done for this hypercoagulable state. Let's talk about that, because that's a very interesting, that's actually, it can be quite, life-threatening, especially people with cardiovascular illness.
Right. So what we see from a vascular standpoint is this concept called microclotting. So with microclotting, these small clots that form. What's different in long COVID is these clots are actually encased in what we call macrophages. So macrophages are one of the immune cells that we use to fight infection. So within these immune cells, we're developing, we call microclots. And what happens when you build up a lot more microclots, it affects the way blood flows. So we are seeing more and more people with cardiac events, especially younger. It could be stroke, it could be heart attack, pulmonary embolism is another example where it affects the lung, deep vein thrombosis. And the reason why is COVID seems for some reason to be a highly vascular type of a virus, that it does affect our vascular system, especially through fibrin. And fibrin is one of the mechanisms where clots form within the body.
So we've talked about the hypercoagulable state. We've talked about the gut microbiome, how it affects our gut microbiome. Blood glucose. This is like your topic. And I know you talked about this at the very beginning, and then I started seeing it in my patients. Major changes in blood sugar regulation, like to a point of where people feel faint after they've had a meal. Like nothing seems to be working. Let's talk about blood glucose dysregulation and post-COVID.
So I'll tell you why I think what's happening and why. So one of the things we're seeing is I call a disconnect. And what I mean by that is where glucose levels don't match insulin levels. And the reason that's important is when glucose rises, typically your body and pancreas will secrete more insulin to move that glucose from the bloodstream into a cell to be used as energy. What's happening in this aspect is two things. Number one is that when the body sees more glucose, the pancreas is actually not making the proper response. It's either one of two things, either producing too little and glucose levels are rising, or when you see what you were describing is producing too much, where there's a huge amount of insulin. And the problem with that is that's driving the blood glucose level too low, where people start feeling faint, feel lightheaded, and other issues like that. The reason why it's probably happening, I think, is twofold. Actually, let me take it back, threefold. So number one, I think, is digestive, right? So one of the issues that happens with blood sugar regulation is the body, when you eat something, the body says, okay, glucose is coming, let's send a message to the pancreas, we need some insulin, it's got to come. The problem, what happens if digestion is off or delayed, that glucose does not get there fast enough, and there's too much insulin sitting there working on the glucose that was there before, and what ends up causing is low blood sugar. So that's a problem. Number two is, and I don't know if you've seen this, is people post-COVID have high iron levels. So we're seeing an unusual lab or abnormality, which is high iron with low or normal ferritin. So typically, when we have what we call iron overload, ferritin, which is a marker of iron storage, is typically high also. We see that in fatty liver and other liver disorders. But post-COVID, we're actually not seeing that. We're seeing normal ferritin in the setting of very high iron. And I suspect that very high iron is affecting the body's way of utilizing glucose. The liver, which is what metabolizes iron and uses it, one of the problems with that is that when you have a non-functional liver, and that's probably with iron overload, the liver cannot take up glucose properly. So you have that. The third mechanism is, and this is kind of more you like to talk about a lot, is dysregulation of cortisol. So what that means is cortisol is our body's ability to handle stress. What often happens, and this is what we talk about in adrenal fatigue, when the adrenal glands, those small little tiny glands sitting on kidneys that cause a lot of trouble and drive us crazy, don't react to stress properly. So when they don't react to stress properly, your body's not going to be able to grab glucose out of its stores to be able to use. So we're seeing people also with either low cortisol, where they can't respond to stress, or too much cortisol, where their body can't stop being under stress. You have a great term for that, wired and tired, I think you call it.
Yeah, wired and tired. For those people listening with cortisol, there's 4 different points of the day that we take cortisol to actually really see, is there a cortisol mismatch. And this is a test that anyone can do. It's a saliva cortisol. It measures free hormone. So we do your morning levels. Your morning levels should be really nice and high. You know that commercial, Zestfully Clean, while the whole family's, in the morning running around, it's a soap commercial. You should be feeling like that in the morning. Then when it comes to noon, your cortisol levels drop. Okay, so you should be feeling, not super energetic, but still alert and good. Afternoon, it further drops. And then by the evening, you should have a very low cortisol versus the morning. And those individuals that have, they're night owls, they can't sleep, those individuals have sustained levels of cortisol. And if that keeps happening over a period of time, what Keith is saying is going to mess up our blood sugar levels. So that kind of insulin resistance, we call it the cortisol belly. Anyone like working out and they're like, I'm losing weight everywhere except for my belly, that's the cortisol belly.
And what's interesting is, and I think that's where people feel a lot of overwhelm, fatigue, or other issues, that can't sleep at night, and that's really critical. And the problem with COVID is it seems to find our weaknesses, which is such a weird concept to say, that people that have predisposing or issues with blood sugar to begin with, or digestion to begin with, seem to get more symptoms of those, or worsening symptoms of those post-infection.
Thank you for saying that, because it does seem to hit people in areas where they already had a weakness, and then it just pulled them down. So anyone with risk factors for cardiovascular disease you didn't know about, COVID is going to tell you. It's almost like the truth revealer of your health. So it's something to really, really look out for. Should we answer another question?
There was someone who asked about mast cell, though. I don't know if we saw that before. That was really interesting. Oh, okay. We could do the cough one, though.
Yeah, well, let's do the cough one now, and we'll go back to the mast cell one after. So Michelle is asking, is a persistent cough months post-COVID considered long COVID?
And the answer is yes. And typically, when you, even with acute infection, one of the last things to improve is the cough. And there's a couple of mechanisms we feel can be causing the cough. Number one is we talked about before about viral pleurisy or inflammation. Yes. That's number one. Or number two, and this is where we're seeing more in Omicron, which has a histamine type of a pattern, and where histamines are, and we'll talk a little bit more of that, are what we see in allergies, causing things like postnasal drip. So we're now seeing postnasal drip and other type of reactions post, especially Omicron, that can also trigger cough.
Let's go to the mast cell question and let's talk about.
I'm asking what you're drinking.
Oh, I'm drinking a celery and cucumber juice, and it's organic. So you have to be careful at juicing this stuff, because if you're juicing a ton of celery and cucumber that is not organic and has pesticides, you're drinking a bunch of pesticides. So I've made sure I cleaned it really well and juiced it. Yeah, it's I just had my beauty collagen cocktail this morning, and with some protein, and now I'm having some juice because I thought I was going to get a bit thirsty, but I like drinking this versus water.
But I'm going to hide my water. Hang
on. Okay, so the histamine thing. Can we go to speaking about histamine first? Because you mentioned the histamine thing, and what I'm noticing as well is that people are post-COVID getting this cough, but also getting allergy-like symptoms. And also when they get COVID, they actually have allergies, which they think is allergies, but it's really COVID. So it's interesting how, this sort of response to certain individuals are getting allergic type reactions that really is COVID.
So what histamines are, we all heard of allergies, right? So histamines are one of our types of inflammatory cells. It's
yes.
actually our first response. We call it innate immunity. So let me give an example. So when someone who's allergic to, say, fish, I'll use my issue, and I get exposed to fish, people will get, their face will start to swell, they'll get redness, they'll get hives, they'll get shortness of breath. That's a histamine response. That's an allergy response. So what's interesting about COVID is COVID seems to be triggering histamines another way. The largest collection is actually two places of histamines. Number one is the digestive tract. Number two is actually the brain, interesting enough. So having a large collection of histamines and these inflammatory cells creates a problem. The problem isn't that they're there, the problem is they don't go away. Because you want, right, when you have an allergy, you want to have a response, right? You don't want to have bad things happen, but you want that response to run its course and end. What happens is when histamines do not go away, it creates what we call a chronic inflammatory response. And that chronic inflammatory response really can wreak a lot of havoc on your body. It affects your immune system, digestion. There was a study recently I read about even Parkinson's, where they saw high levels of histamine in one part of the brain. That inflammatory response from those high histamines is going to cause damage in a lot of areas. And again, when we look at, we talked a little bit before autoimmune is a chronic inflammatory response, is one type of it. And actually that will also, when other infections get triggered, high histamines can also weaken the body's immune response to let these other, I call them caged viruses, out and to run amok around our system.
I love that. The caged viruses get released by the corrupt police officers. And then everybody's
Officer
out.
Histamine.
Yeah, it's a histamine storm. And,
yeah.
So, we are going to talk more about next week what to do. Definitely quercetin, vitamin C, stabilizes those mast cells. Really important about stabilizing the mast cells versus dealing them. And antihistamines, believe it or not, that really helps take them out of their acute coughing phase,
Yes. And again, remember, when we go back to how COVID started, it's nasal, right? So nasal, they're usually your first response. And again, that's why people are so confused today. Do I have allergies? Do I have COVID? I know. You honestly can't tell anymore. And that's because they're both histamine type responses. The one difference though I do see, and this is kind of interesting, with COVID, I don't see as many of the eye symptoms, right? People who have acute allergies, environmental allergies, get a lot of the watery eyes and things like that. Yeah. I'm not seeing that with COVID. I see more of the nasal, the sore throat, those kind of symptoms more so than just, as well as the watery eyes.
The other thing that I'm seeing is I'm seeing people with poor eyesight post-COVID, that they're going to get their eyes tested and they're seeing lower levels of, their visual changes are there. So once you get this virus, I mean, it's kind of like when somebody has HIV in a way, right? Once they have HIV, they have a high susceptibility, they're immunosuppressed. Does COVID indeed cause immunosuppression once you get it?
And the answer is yes. And if you actually look traditionally, viruses do that, do that normally. So when we call white blood cells, right? Typically we have those are our infection fighters. If for a bacterial infection, it's usually what we call neutrophils. Neutrophils will rise, you'll have a higher white blood count. With a virus, it's lymphocytes. It's a different strain of white blood cells. The difference is in a viral infection is the white count can actually drop. So you can have a much different picture where virus can suppress what we call the bone marrow, which is what produces our white blood cells, using and causing that white blood cell to drop. And I do see that a lot of individuals would suppress white blood cell counts, where normally it should be no lower than about 3.5 to 4. I'm seeing people 2.8, 3.1, 3.2. And it could be months later after COVID. Absolutely. And I wonder if that's also making them more susceptible to these other viral infections that are cage virus.
Absolutely. That they release and the criminals come out and, they attack while you're down. That's just what's happening.
And actually, what's interesting, I don't know if you're seeing this, we're seeing summer viruses very high this year.
Oh yes, for sure. And
I never knew that was a term, by the way.
Oh, the summer colds, yeah. We do have summer colds every year, but this year in particular, I mean, we have so much going on between people having, allergic type symptoms, post-COVID, pleurisy type stuff, bronchitis, acute bronchitis, and a lot of these patients, it's turning, if they don't do anything about it, it's turning bacterial.
Yeah.
So they're getting back on antibiotics. The antibiotics are now wiping out the good bacteria. Then they're going back to increased risk. I mean, it's getting candida. I mean, it's going in one big circle. So it's like you have to break the cycle at one point. And, don't forget anyone here today to join us next week, because we're going to be talking about what to do.
So I actually did not give statistics in the beginning. That's not like me, but I'll make it up now.
I know. What's happened here, Keith? You're slacking off.
So the U.S. government actually has statistics on long COVID. So it's the General Accountability Office, which is the Inspector General of the government. They suspect that 7.7 million to 23 million Americans have long COVID. Tremendous amount. Actually, it's such an epidemic that actually it's now covered on the American Disabilities Act.
Yes.
That it's considered actually a disability. And I think the problem is, and we started talking before, is that I think a lot of people don't know their symptoms are symptoms of long COVID.
Right.
I think because I don't think I've ever faced an illness before that has so many different presentations that we're seeing today.
It's true. When you do a consultation with a patient, and they'll even say that this is the most, and add mental health onto that, their mental state,
Can I talk about that for a second? I want to talk about that.
Yes, it would not be alive without talking about that.
So, because there's really interesting stuff about, and this is where I think also where long COVID comes in. So we've talked before about the genetic aspect of what we call MTHFR, which is a gene that affects the body's ability to use folic acid to become methylated folic acid. Why that's so important is in the methylated form of folic acid, it's the precursor to a lot of our neurotransmitters, serotonin, norepinephrine, dopamine. That's important. So what's interesting is people, and I'm seeing this more and more, that have this genetic issue called MTHFR or have this gene, especially if they have both copies, are seemingly getting more severe long COVID. They actually, because it's affecting their body's ability to handle stress. One of the things that serotonin, dopamine, norepinephrine do, and these other neurotransmitters, affect the body's ability to handle stress. The second thing, what's interesting, and also we know there's a link, well, now it's all off about serotonin, with the controversy in medications, but there is a link with that and mental health. Where the other aspect is, if the gastrointestinal tract is affected, that's where a lot of these neurotransmitters are made, especially GABA. GABA, which is, we love most GABA because GABA is the primary inhibitory neurotransmitter, allows us to sleep at night. Without it, we can't sleep. Whereas serotonin is also inhibitory. Dopamine's interesting because it works both ways, excitatory and inhibitory. And when those are off, and those are mostly made in the digestive tract, it's going to affect the body's ability to handle stress, but it's also going to affect people's mood. So we are seeing more anxiety, more depression, very, very high levels of, and interesting enough, in people that really never had it before, which is what's really different. I'm hearing over and over again, people feeling more anxious a lot of the time where they really have no history and no family history of having anxiety in the past.
And the thing is, Keith, we don't make these B vitamins in our body. We have to take them orally. And, you know, the more stress you're under, the more B vitamins you need, the more vitamin C you need. Your body almost like burns through it as you need it. It's like burning a candle at both ends. You know, if you already are stressed, have a stressful job, adrenal fatigue on top of that, and you catch the virus, you're going to be down longer. And, you know, taking these B vitamins are so important. They're not just good for the adrenal glands, but they're good for blood sugar regulation. They're good for cognitive function. And they're so important to take.
Actually, there's a huge study just released about B6, which is, we often use that. Folic acid's B9, and then you know B12. B6, huge study on showing using B6 as treatment for depression. I mean, there's a huge study just released showing how effective it is in impact. And you said so importantly is you need them all. So you have to, a cocktail of that is actually very effective.
And that's for everyone. Chrissy, I know you're asking what's my favorite B vitamin complex. Of course, I'm going to say the one I created. It's called B Famous. It has B1, B2, B5, B6, 5-MTHFR, which is what Keith and I were talking about. A lot of people have this genetic mutation that they're not able to absorb it in their bodies, and higher doses of B complex without causing that irritation in the gut. B vitamins can cause that kind of irritation, so make sure you take them with food.
So I want to bring something up about MTHFR. So people have to be careful sometimes with supplementing folic acid. If some people who have more depression, anxiety, or it's more severe, you may have to go slowly. And also you may actually have a niacin deficiency. So when you do take, you want to go slowly because of that.
That's good to know. So somebody's saying, let's see. When hubby got the first vaccine a month ago, prescribed antibiotics, opted not to take compromise. Immunity idea was bad or good? The virus the first time a month ago.
Oh, got the virus the first prescribed.
Okay, so she's asking, my husband got the virus and he was prescribed antibiotics. So that was sort of the treatment because of the anti-inflammatory effect. I mean, it depends on how bad he was, right? Like if he was hospitalized.
Yeah, sometimes we use, and this was more in the earlier strains of the virus, more the alpha, beta, gamma, delta strains, where we use antibiotics as an anti-inflammatory, especially zithromycin, and also doxycycline. And
it worked really well with people who are hospitalized. We're not treating using the antibiotics as an antibiotic. It's more for the inflammation.
Correct. And what's so important, and I think people in any illness, early treatment is so critical.
Absolutely. Absolutely. What else are we forgetting, Keith, to talk about long COVID? Any other questions, you guys? You can post them here. We answered the histamine question. We talked about GI. We talked about coagulability.
You want me to talk about the autoimmune?
100%, because we're seeing a lot of elevated ANAs after, and thyroid peroxidase elevations after COVID. Let's talk about that.
So it's interesting. What's different is it's called thyroid peroxidase, antibody, and that has a lot to do with autoimmune thyroid, and as well as anti-nuclear antibody, which is more sensitive but not specific. So it could be for any rheumatological, it could be also autoimmune. The difference is and what I'll do in a lot of these cases with this new antibody, especially in thyroid, is we'll do an ultrasound. The ultrasound is normal, so it doesn't show the thyroid being damaged, but it's a transient autoimmune response that can get better and go away. And we'll talk, next week a little bit more about treatment, but there are treatments to really decrease. Remember, autoimmune disease is really driven by a couple of things, and we talk about this all the time. Number one is digestive, right? Whenever we see autoimmune, people always have a digestive issue first. Immune system starts your digestive tract. Number two, it's runaway inflammation. So it's really working on that inflammatory process, histamines being one. The other one, we talked about cytokines. Early on, the term cytokine storm became popular. That's a marker. And in long COVID, that's also another thing we often see is persistent inflammation, where people have persistent cytokines or histamine levels that are elevated, wreaking havoc around the body. What's interesting about the autoimmune is also we're seeing people that have history of autoimmune disease that actually have been dormant for several years are having reoccurrences now post-COVID.
Think about it this way, everything you said about the runaway train, the inflammation, we have something called T helper cells and T suppressor cells. T helper cells are like the gas pedal, T suppressor cells are like the brake. When you have the gas pedal going at the speed of light, the light at the speed of light, and the gas pedal is not working, it's broken, that's an autoimmune condition. That means your immune system is responding to everything and anything without, any proof of anything. It's just attacking everything, including your tissues. And so that can be a long process to heal if you don't get to the root cause, which is what Keith was talking about.
And again, even though your immune system you think is working, it's really dysfunctional at that point.
Yes.
It's really not effective. So that's the bigger problem. And what happens is it's not recognizing the inflammatory process for what it is, and it's not able to always treat it properly. And that's why we're seeing again, going back to the reactivated virus question, that's why we're seeing people developing also these reactivated viruses, because their immune system is not recognizing them properly to treat it properly.
All right, we have another question here, Keith. So how does one clear residual persistent nucleocapsid and spike proteins in LC?
So there's a couple interesting things that do seem to work. Vitamin C seems to have an effect. Vitamin C is a very powerful antioxidant. One of the ones that's really interesting that we're learning more and more about is melatonin. So melatonin, although people know it for sleep, it lowers cortisol. That's why it's very helpful. It also is very important in the innate immune system. Actually, we have two immune systems, and I'll explain that quickly. There's the innate, which is the initial immune system, and then there's the acquired, which people develop a couple weeks later. That's when we have an antigen-antibody response. The other one that's really interesting that seems to have an effect is this concept called autophagy. So autophagy is, and I don't know if anyone who's read about intermittent fasting, that's what the process of intermittent fasting is, the body's ability to actually clean itself out. It's all to get rid of what we call cellular debris. And that seems to happen when people actually give more hours where they're not eating. Typically, people will eat and eating 3 or 4 o'clock during the day and not necessarily eat to the next day. And depending on the person, that could be different times. Yeah. And that concept actually allows the body to repair itself. I think you told me this. In Ayurvedic medicine, the liver heals, right, 11 p.m. to 4 a.m.? Is that right?
Mm-hmm.
So
also, celery juice helps with autophagy as well.
So those, and we'll probably talk about that a little bit, next week. But those are the big ones that do have an effect.
Interesting. Blue Blood Guru, you've got a lot of cool information. Amazing. Let's see. Tayana. Yay.
I'm so impressed.
Diana. Sorry?
It must be 8 o'clock at night for her, 9 o'clock at night.
I know. Antibody treatment once down with COVID, injecting antibodies caused a bad reaction. Your opinion on this, please.
Okay. So, and what I think she's referring to is monoclonal antibodies.
Yes.
So I do have cases where people did not tolerate monoclonal antibodies.
Yeah.
They seem to share something in common. A lot of these individuals have high histamine levels where they actually also have a history of reactions to previous immune issues like a previous flu shot or other things where they have a very hyperimmune system where they can't handle the excess immune response. Remember, you're actually giving someone antibodies, so you're causing the immune system to even become heightened, and that's the key to try and fight it off quickly. And someone who has sometimes a hyperimmune response to begin with doesn't tolerate that additional immune stimulation.
Absolutely.
I have about 5 cases.
That makes sense. That actually makes a lot of sense why those people are not responding as well to the monoclonal antibody treatment. Okay. One thing for everybody to note on this live today is that the body has innate ability to heal itself if given the right environment. So we're giving you information about what we're seeing in clinical practice, what we're, hearing from other patients, what we're, observing in the literature. And what we're going to do next week is take all that information and put it together in a user-friendly way of, basically how can you prevent and treat this. Actually, I do have a question as well. You have you shield. Or we're not going to talk about that.
We can if you want to.
Okay.
So that's a monoclonal antibody.
Yes.
And in what aspect? So what?
Well, as in there are patients, there are some practitioners who treat a lot of autoimmune patients who are not giving them the conventional style protection treatment for the virus. They're giving the monoclonal antibody. What are your thoughts there for preventative?
I mean, I haven't used it in my own practice. I have a different style. The nice thing about medicine is art. I mean, people do it. I have seen it before. I just don't know long-term what effect that's going to have. And that's my question. And that's what I don't know. I mean, I've heard people do really well. I mean, but they've been using it more and more. But the interesting part is, again, does it work on every strain? Or every variant is always a question. Because the thing about monoclonal antibodies, they're usually very specific to different variants.
Yeah, this is true. This is true. Yeah, interesting. Yeah.
But anyone who has any good data or literature or information, please share it. That's the great thing about medicine is it's a team effort, and we need to work together to learn together.
Absolutely. Sharing is caring. So what I think we should do is anyone has a few more questions, we can answer a few more questions, and then we can have you guys next week, and it's going to be so exciting. We're going to have Dr. Paul Anderson on with us. He is incredible. So it's going to be Keith, myself, and Paul Anderson. That is going to be triple threat, amazing conversation on this. So
do you know what a dream is? I get to question a naturopathic doctor. How awesome. Reverse the roles.
It really is. Yeah, I mean, the thing is like we're such a good marriage, conventional medicine in the sense of what, I feel is very antiquated. Like it's like a top down, he's not looking at the root cause of why somebody's actually, it feels to me not as scientific. I think what I look at with conventional docs is they're great for emergency care, for the acute, but for the chronic, it's like those people that are left to fend for themselves, and telling a patient that what they eat is not going to actually help them get better, to me is really negligent, because we put food in our mouth and we also put the antibiotic medication they give us in our mouth. So why is there a difference? Do you know what I mean? Like, it's so strange.
Well, I think what it is it's focusing on one system at a time and not the consequences of that. And I think that's a problem. We now know that everything has a consequence. When you do something for the gastrointestinal tract, it can affect the cardiovascular, the heart. So you have to kind of look at them as a whole. And I like you're saying before, to kind of flip that top-down approach to go bottom-up and really build a good foundation. With a good foundation, people end up staying healthy and they don't get as sick.
Yeah, absolutely.
No matter what the problem is.
Yes, no matter what the problem is. I know we said we weren't going to talk about treatment. I just want to talk about one thing, the sense of smell that everybody's talking about. I read this somewhere, and I don't know where it is, Keith, if you've read it as well. Essential oils, inhaling different essential oils every day. I can't remember which ones they were, but different, like just getting your olfactory system like acquainted with really pleasant smells can actually bring that back. And B vitamins as well.
I use intranasal glutathione. I've used as well for that. Citrus bioflavonoids have an effect as well. So depending on what effect, this again, the question is that also histamine type response given the area of the body where that's affected?
Yeah, and all these essential oils do help the sinuses and kind of open that passageway. Good, citrus-based essential oils. Who would ever know that we'd be talking about essential oils in major studies after COVID to get your sense of smell back?
But I think people want to know everything to see if that is. Oh, can I answer? I want to answer this question. Is there an official test to see if someone has long COVID? The answer is no. That's one of the issues because it's so many different patterns. I mean, I think it depends if it's inflammatory or post-viral, or we talked about vascular, we talked about histamines, we talked about gut dysfunction, we talked about, as well, blood sugar dysregulation. Those are all possibilities for long COVID, but they're all diagnosed very differently.
Perfect. Well, we're time up here. I've got to go and see patients, and I know you do too, Keith. This was super fun. Thank you for everyone who joined us. Please come back next week. We are magic, Keith. Thank you so much, Amala. That's so sweet of you. And so we'll see you here next week, same time. It's going to be 11 a.m. PST, 2 p.m. if you are out where Keith is in New York, in the East Coast.
We can switch. Now we're heading into fall. I'd rather be in California.
I know. Come to California. Come and see us over here. Dante and I are waiting for you. All right. Thank you, everyone, for joining us today. That was so much fun. Our first live back. It just feels good to do this again, doesn't it?
Yeah. And again, keep the questions coming. So it's really good it's thought provoking. And also other people may benefit from the questions you ask, which is really critical as well.
100%. Thank you, guys. See you next Wednesday.